Good afternoon. Thank you for tuning in during this rather busy period before the Chinese New Year. What I hope to do over the next half hour or so is to talk a bit about heart diseases in children and to explain the presentation, how they are diagnosed and how they are managed in our hospital. Right, I will start with congenital heart disease, and as you know, congenital means a child is born with the heart disease. This is as opposed to acquired, where the heart is normal at birth, but the child falls sick and acquires the heart disease. Now, many parents are a bit worried or a bit shocked when they are first told that their child has heart condition. But surprisingly, it is not a rare condition. The global prevalence used to be about 0.8 per 100 live births, but nowadays with better screening and with better detection and more awareness, we believe that the prevalence is about 1.8 per 100 live births, and this holds true across all nationalities and races. So that means there is no racial preponderance. Now, what do we do when we are faced with a baby or a child with a congenital heart disease? First of all, we classify our children into two major categories. The first is whether the child is pink. So we look at the lips, we look at tongues, we look at the fingers and the toes, and we see and observe if the child is pink or if the child is blue. Thankfully, most of or the majority of cases of congenital heart diseases, the children are pink. About 20% present with cyanosis or with blueness of the mouth and the fingers and the tongue. Now, once we have decided whether the child falls into the cyanotic or the blue category or the pink or acyanotic category, we then observe the child and decide whether the child has got heart failure or whether the child is stable. So what happens is when a child is brought to our clinic and we want to decide whether the child is in failure or not, we usually ask a few questions. So the first question that we usually ask is, how is your child feeding? More so a baby. How much milk is your baby feeding? How long does it take your baby to feed? And when your baby is feeding, does your baby sweat a lot? Or does your baby have to stop to take deep breaths for feeding? And we monitor the weight gain. So usually when babies go for vaccinations in the government clinics or in any GP clinics or pediatrician, we will always plot the weight of the child across what we call percentile charts. So as you can see, if something happens to the weight gain, for example, in this case where it becomes, it becomes a bit flatter, or if it actually falls or decreases, then we know that something is very wrong with the feeding. So this means that the child is not taking normally, and this means that the child is having failure. The other thing is in the clinic, we monitor the breathing of the baby. And what we notice in this abnormal case is when the child breathes, you can see that the chest wall sinks inside. And this is because the baby has got to take deep breaths. And likewise, the abdomen, if you look here, it is very prominent, the creases beneath the rib cage. So this is another clue to doctors that the baby is having heart failure. And because of the heart failure, there is increased work of breathing. And the increased work of breathing gives rise to these signs and symptoms that a doctor would look out for. Now I want to go on to the most common congenital heart disease. And this is what we call a ventricular septal defect. Now this is a hole in the heart. So when people talk about children having holes in the heart, this is what we mean. You can see that the heart has got 4 chambers. You've got the left-sided chambers, you've got the left atrium, a left ventricle, and you've got the right-sided chambers, which is the right ventricle and the right atrium. So you can see that the blue blood without oxygen is on the right side of the heart, and the pink blood, which carries oxygen, is on the left side of the heart. And now there is a hole inside the wall of the heart, and this is what we call a ventricular septal defect. Now this defect accounts for about 25 to 30% of children with congenital heart disease, and by far is the most common heart condition. So you can understand that if the baby has a huge hole, the baby will develop heart failure because too much blood flow is crossing this hole. Whereas if the hole is small and there's less blood crossing the hole, then the baby will be asymptomatic and the baby will not have any features of heart failure. So when the hole is small, children with a ventricular septal defect may have spontaneous closure of the hole, which means with time, we just have to monitor and see if the baby is stable and growing normally, and we hope that it will close spontaneously. But in about 20% of babies who have VSDs, the hole is just too big and it will not close by itself. And what happens is we will need to operate, or sometimes if we can, we try and put in a device or an umbrella to close up this hole. So that is a ventricular septal defect. Now there is another different type of hole in the heart, and this time you can see the hole is in the upper chambers or in the upper room, unlike the VSD just now where the hole was in the lower chambers. Now this hole is slightly different from the VSD previously because usually children with this kind of heart lesion, they are very well. They do very well in school. They have no signs or symptoms other than perhaps they might have more frequent chest infections, more coughs, more colds compared to their brothers and sisters. But if a murmur or an abnormal heart sound is picked up when the child is examined in the school or when the child is brought to the doctor for another illness. And usually in these lesions, if we miss them in childhood, they will present in adulthood with problems like heart failure or an irregular heart rate. Or sometimes in ladies or in women, what happens is it will be picked up during pregnancy. The problem is if we pick it up during adulthood and we operate, or if we close this hole in the heart when they are in their adulthood or adolescence, they may not live up to a normal age as ordinary people, so which means their lifespan becomes shorter. Or if we operate too late, sometimes the heart rate becomes irregular and they need to be on lifelong medicines. So that is why in school children, the nurses or the doctors from the government clinics will check them once in standard 1, and we try to pick up these murmurs even though they are well and healthy children. Now, other more common conditions would include this called a pulmonary stenosis, where there is a narrowing of the valve leading into the lungs. This accounts for about 9% of cases with congenital hearts, and the children here are usually pink, and again, they are usually very well and asymptomatic, and when they go and see a doctor, then the doctor will pick up this incidental abnormal sound in the heart, and they will tell the parents. Now, years ago, we used to operate to open up this narrowing, But nowadays, with new techniques, what we do is we put a balloon from one of the veins inside the thigh. We lead the balloon through this valve, and we use the balloon to blow open this valve. So nowadays, children no longer need to go for open heart surgery to treat this condition called a pulmonary stenosis. Now, this is a unique kind of heart condition called a patent ductus arteriosus, where this blood vessel, which joins the left-sided aorta to the right-sided pulmonary artery, fails to close within the first week of life. In all newborn babies, this PDA will eventually close, and we usually give up to a week and sometimes even to a month for it to close spontaneously. But in newborn babies who are born prematurely, sometimes this blood vessel called a PDA does not close. And as you can see, because it does not close, a lot of blood will flow back into the lungs, and like the VSD or the hole in the heart, this extra blood will cause the baby to go into heart failure. And this is usually seen and classically seen in babies with prematurity. Another condition which involves a blood vessel coming out from the left side of the heart is called a coarctation of the aorta, and there is a narrowing here, which is the main blood vessel coming out from the heart. And as you can imagine, if there's a narrowing here, what happens is the pressure in the heart on the left side will increase, and the heart will become swollen and the muscles become thicker because the heart has to work harder to pump blood across this narrowing. And because of the high pressure, some children can develop high blood pressure. And if this is not picked up when they become adults, the high blood pressure becomes irreversible. And again, in the old days, we used to operate on children with this condition, but nowadays, we can put a balloon again through this narrowed portion. We blow up the balloon, and this will open up the narrowing. Now, I want to move on to a different category, or what we call the blue babies, or children who appear blue. So if you look at this child, if you can appreciate on your laptop or on your computers, you look at the lips and the tongue of this baby, it is not pink. Likewise, if you look at the fingers, they do not appear pink. They have a bluish discoloration, and there's actually what we call clubbing, which means the fingers look like clubs or a bit like a spoon because of the lack of oxygen. Sometimes in newborn babies, when we are not too sure if the oxygen is normal or not, we can actually check with a machine called a pulse oximeter, which is clipped on. It's just like a clip. You just clip it onto the fingers, and the machine will measure the oxygen for us. And for most of us who are normal, the level should be about 97 to 100%. But in babies who are blue, usually the level is below 93%, and sometimes in very severely cyanosed baby or severely blue babies, it can go all the way down to 85%. Now, the most common blue heart condition is what we call the tetralogy of Fallot, where there is a mixture of findings inside the heart. So there is a large VSD or a large hole. There is narrowing of the blood vessel going into the lungs, and because of that, the blue blood mixes with the red blood and the child appears blue. These conditions need to be managed in a tertiary center, and they also eventually need surgery. And another condition, which is called a transposition of the great arteries, is a very critical illness in the newborn babies because it is very dangerous and life-threatening. What happens is that the blood vessels are switched during development. So what happens is the blue blood that comes back from the body goes back to the body bypassing the lungs. So what happens is that blue blood goes into the brain, it goes into the liver, goes into the intestines. So there is not enough oxygen in the newborn baby, and the baby becomes very, very severely ill. And if we do not do anything, what happens is the baby may die from lack of oxygen and from the build-up of acids within the body. Right, I have touched on congenital heart disease, which is what the baby is born with. And now I would like to move on to the next heart condition, which is an acquired heart condition. And when I say acquired, it means that the baby was born normally and the baby caught an infection, and because of the infection, it has damaged the heart. Now, many years ago, about 30, 40 years ago, the most common infection or the most common acquired heart disease is rheumatic heart disease. I'm sure many of you have heard of rheumatic heart disease, but nowadays we hardly see rheumatic heart disease due to the improved quality of life, improved health care. But what we see now is a condition called Kawasaki disease, which is named after a Japanese doctor who first described this disease among Japanese children in the 1960s. And the thing about Kawasaki disease is it affects Oriental children more than Caucasians and more than the African races. So what is Kawasaki disease? We don't really know the cause of the disease, but we know that usually it is triggered by an infection, most likely a virus. And the most important sign of Kawasaki disease is a fever which takes a very long time to settle. And we usually say the fever will last beyond 5 days. And the thing about the fever is it does not respond to your paracetamol, and sometimes you've got to use your suppositories. But even after that, the fever will swing up again. So when you have a baby or a child or a toddler with a fever beyond 5 days of life, please remember Kawasaki disease. Now, on top of the 5 days or longer period of fever, we look out for other signs like conjunctivitis, which is redness of the eyes, mucositis, which is redness of the lips, swelling of the fingers and the toes, a rash on the trunk, and a swelling of the neck lymph nodes. So this is what we mean by conjunctivitis in Kawasaki disease. If you look at the eyes, you can see that the whites of the eyes are a bit red. They are inflamed. And the conjunctivitis in Kawasaki disease is different from the common viral conjunctivitis because you don't get a discharge. In the common red eyes that you see, usually you see a lot of yellowish discharge, a lot of tearing. But in Kawasaki disease, it is non-purulent. You don't see any pus. And what I meant by mucositis is that the lips of the child becomes very red, very inflamed, sometimes to the point of being cracked. And if you look at the tongue, sometimes they have this typical finding, what we call a strawberry tongue, because it looks like a strawberry. So these are the two commonest features of Kawasaki disease on top of the fever, conjunctivitis and mucositis. Then we look for swelling of the limbs, extremities, the feet and the fingers. They can get a rash on the trunk, any type of rash. And sometimes, sometimes what you get is a swelling in the neck. Now, why are we worried about Kawasaki disease? We're worried about Kawasaki disease because it can actually cause damage to the arteries inside the heart. By the time you see this, which means peeling of the extremities, which means peeling of the fingers and the toes, and if we have not treated the child within the first 10 days, we are already too late. The damage is done. So we must try to recognize and diagnose Kawasaki disease before 10 days of fever We must treat before 10 days of fever so that we do not wait for the desquamation or the peeling. Another unique feature of Kawasaki's in infants or in babies will be a swelling of the BCG. As you can see, the BCG here is very red and very swollen. So this is another clue to look out for in Kawasaki's disease. And like I mentioned earlier, the reason why we are so worried about Kawasaki disease is that if the blood vessels inside the heart becomes swollen, it becomes inflamed, then it is damaged. Then what happens is that you can get clots inside these arteries, and these children can actually get a heart attack, which you usually don't see in children, but usually in the middle-aged and the elderly. So these children with Kawasaki disease, we have to monitor them very carefully as they grow up to make sure that they are not at increased risk of developing heart attacks. Right, so that's the end of my talk, and we will now go on to the question and answer segments. If you have any questions, please do key them in, and I'll try to clear up any doubts or any queries that you have. Right, now, what prenatal tests are there to determine if my child has a birth defect? Now, right, nowadays what happens is when a pregnant mother goes to an obstetrician, most obstetricians are already trained to look at the baby's heart in utero, which means when the baby is inside the mother's womb. They do some basic important tests, like they look for the 4 chambers or the 4 rooms inside the heart, and they look at the 2 main vessels which come out from the heart. And if they find that, oh, it looks a bit abnormal, it doesn't look very right, they will usually refer to a pediatric cardiologist, and we will then perform a more detailed scan of the fetus's heart, and then we will decide whether it is a critical condition, because if it is a critical heart condition, then mother has to deliver in a hospital which is ready and well equipped to deal with children with heart conditions. In the old days, when we could not diagnose in utero, when babies are born with these heart lesions, in the rural areas, they had to be rushed by ambulance with oxygen, with drips to the nearest general hospital for further treatment. So now that you can detect the heart condition in utero or inside the mother's womb, you can prepare to stand by during delivery. Right, now, next question. After treatment for a heart defect, will there be residual issues in the future? Right, what happens is sometimes in certain kind of heart conditions, like for example, the patent ductus arteriosus and the atrial septal defect, if you treat them early, which means if you operate early enough, then usually the child, as he grows up, he becomes like a normal adolescent, he becomes like a normal adult, which means they live a normal lifespan, they are not prone to more infections. But there are some very complicated heart conditions that even though when we operate on them, they are not fully cured, which means we still have to monitor them, we still have to follow them up every year, and we've got to look for further complications, like sometimes they may need a second surgery or even a third surgery, sometimes they need to be on lifelong medicines, and sometimes they might even need a heart-lung transplant. Right, another question is, how often should I bring my child to the pediatrician? Okay, right. Again, this depends on the heart condition, and this depends on the severity and complexity of the surgery. If it is a very complicated, a very complex heart condition, and if the surgery is very complicated, then we will need to review very regularly, even sometimes up to every 6 monthly, because we want to make sure that the child has got no sequelae or no complications from the surgery. What is the likelihood of me having another child with a similar? Right, this is a very difficult question because I know when a baby is born with a heart condition, usually almost always the mother gets blamed. And the mother blames herself because she says, oh, what did I do? Did I eat something which was wrong? Or did I do something wrong? Did I not take care of myself? Was it the fever that I got that caused my baby to be abnormal? But all this is not related to the heart condition, because the congenital heart defect is multifactorial in origin, which means there are many factors involved and we do not know what causes it. But yes, if a first baby has had a heart condition, and more so if the baby has got associated signs, like the baby has got a chromosomal disorder or a genetic disorder that predisposes to a heart defect, yes, there's a slightly increased risk that the second baby might have a same condition or a related heart condition. So generally, we say that the risk is about 1 to 5% if of getting a second baby with a similar heart condition. And if two babies or two children in the same family have already had a heart condition, then the risk of the third child can go up to about 10%. But like what I mentioned earlier, you can actually detect all these conditions in utero or when the baby is inside the mother's womb. Last question. Growing up, can my child participate in physical? Oh, all right. Again, this depends on the heart condition and again on what type of surgery. Obviously, if it is a simple heart condition and the surgery is a very basic, simple one, then yes, the child can take part in all normal activities. I know of many children who have small holes in the hearts, and because the teachers are now so worried about losing children in the hospital, children in the school, they make the poor child sit in a corner while all the friends are running around and taking part in sporting activities. So no, we do not want children to become cardiac cripples just because they have a small hole in the heart. So no, they are allowed to take part in all normal activities if it's just a simple lesion. But obviously, if the child has had complex surgery and has a complicated heart surgery, then we will need to make sure that we advise them not to take part in competitive sports, but they can take part in normal activities as long as they know their own limits. Likewise, in Kawasaki disease, if we treat the child well and if we treat the child completely and early, before 10 days of fever, then if there's nothing wrong with the coronary arteries, then yes, the child will have normal physical activities, the child will have normal exertion tolerance. So yes, they can take part in all kinds of sporting activities. Right, thank you very much. What are the chances of a parent passing down? Okay, last question. Okay, I'll answer the second part first. Kawasaki's disease, no, it is not an inherited condition. It is an acquired disease, which means the children are born normally, so they will fall sick when they catch a virus or when they catch a bacteria, which triggers the Kawasaki disease. The chances of a parent passing down heart defects, very rare, about 1 to 3%. So yes, a parent with a heart condition can have normal children, so they need not worry excessively. Okay, I think that's the last one, right? So that's the end of our session for today. Thank you very much, everyone, and Happy Chinese New Year. Bye.